Hi everyone. Hi everyone. Welcome to chapter 15, the special senses. In this lecture presentation, we are going to talk about the eye and its structure and its function. With related to the special senses, uh, the sense of touch is one of the general senses which is mediated by general receptors. And we have covered that in chapter 13. The special senses of the body include vision, taste, smell, hearing, and equilibrium. All use special sensory receptors, and they are very distinct and localized in the head region. 70% of the body's sensory receptors are in eye, and half of the cerebral cortex is involved with the visual processing. So, learning about the eye is very important, and let's look at its structure first. The eye is a small sphere, it's only 1/6 of surface visible, and most of the eye enclosed and protected by fat cushion and bony orbit because it's a very delicate structure. The bony structure, which gives a hard structure around it, and the fat layer is cushioning, and you might have seen that it at the lab, like the fat layer you might seen as yellowish or light yellowish color tissue, or like more towards whitish inconsistency. The eye also consists of accessory structures and the eyeball. So as you can see it in here, you would see the surface anatomy of the right side of the eye, the eyebrow, eyelid, eyelashes, and site where the conjunctiva merges with the cornea, this rim area, the palpebral fissure, iris, as well as the pupil, and so on. So accessory structures of the eye includes the eyebrows, eyelids, conjunctiva, lacrimal apparatus, and the extrinsic eye muscles. The accessory structures protect the eye and aid the eye functions. And let's look at these structures a little bit more. Eyebrows, it overlie the supraorbital margins, and the functions include shade eye from sunlight, prevent perspiration from reaching the eye. The eyelids, also called as palpebrae, it's very thin, and skin covered folds which protects the eye anteriorly. They are separated at the palpebral fissure, and it meet in corners at the medial and the lateral commissures. The structure called lacrimal caruncle, located at the medial commissure, contains oil and sweat glands of the eyelids. And also, there's something called tarsal plates in the eyelids, which supports the connective tissue for folds, as well as it anchor orbicularis oculi and levator palpebrae superioris muscles. Eyelids blink reflexively every 3 to 7 seconds. That will protect from foreign objects and spread secretions to moisten the eye. So any paralysis of the eyelids will lead to dry eye. Eyelashes have follicles that are innervated, and these nerve endings initiate reflex blinking. There's also lubricating glands associated with the eyelids. Some of them would be tarsal or meibomian glands. They're modified sebaceous glands which produce oily secretions and lubricates the lid and the eye. And then the ciliary glands between the hair follicles, which are modified sweat glands. So here you would see the some of the parts of the eye that we have discussed. The eyelids over here, the tarsal glands, the palpebral conjunctiva, the cornea, and then eyelashes, the bulbar conjunctiva, conjunctival sac, so on. The accessory structures of the eye includes the conjunctiva, that is, the conjunctiva is a transparent mucous membrane which produces a lubricating mucus secretion. The palpebral conjunctiva is a membrane that lines the underside of eyelids. And then the bulbar conjunctiva is the membrane that covers the white of the eye, not the cornea. You have to remember, it's only the white of the eyes. So the bulbar conjunctiva contains small blood vessels, and you can see easily that in a bloodshot eye. So what you need to remember is the conjunctiva is a transparent mucous membrane, and it can be divided into two major parts: palpebral conjunctiva, which goes underside of the eyelids, and the bulbar conjunctiva, which covers the white of the eye except the area of the cornea. And there's something called the conjunctival sac, which is the space between the palpebral and the bulbar conjunctiva. And clinically, it's important, that is where the area that the contact lens rests. Another accessory structure would be the lacrimal apparatus. It consists of lacrimal gland and ducts which drains into the nasal cavity. And the lacrimal gland is located in the orbit above the lateral end of the eye, and it secretes lacrimal secretion. And this secretion is dilute saline solution containing mucus, antibodies, and antibacterial lysozymes. The blinking spreads tears toward the medial commissure, and that would enter paired lacrimal canaliculi via the lacrimal puncta. And then the tears drain into this lacrimal sac and the nasolacrimal duct, which empties into the nasal cavity. So that's why, based on the anatomy, if you would look so, you would see that when you cry, sometimes your nose gets watery. It's because the secretions have a connection to the drain. This anatomy leads to drainage of the secretion towards the end of towards the nasal cavity. The another accessory structure would be the extrinsic eye muscles. It's 6 strap-like extrinsic eye muscles. They originate from bony orbit and insert on eyeball. It enables eye to follow moving objects, maintain shape of the eyeball, and hold it in the orbit as well. There are 4 rectus muscles which originates from the common tendinous ring. They are superior, inferior, lateral, and medial rectus muscles. There are 2 oblique muscles move eye in vertical plane and rotate the eyeball. They are the superior and inferior oblique eye muscles. And in this figure, you would see the rectus muscles, the superior, medial, and lateral, as well as the superior oblique and the inferior oblique eye muscles. And you would need to know what is the function of these eye muscles, as well as what nerves that these muscles are innervated with. They are the cranial nerves, so which cranial nerve? And you would see there the involvement of the sixth cranial nerve, third oculomotor cranial nerve, as well as the trochlea. The clinical importance of the structures so far we have discussed is that with related to the tarsal glands, if it's infected, we called it as an encephalocyst or chalazia. And the inflammation of any of the smaller sebaceous gland in the eye, we call it as a stye. And also, it's a common word that you might have heard, the conjunctivitis, which is the inflammation of the conjunctiva, resulting reddened, irritated eyes. And the pink eye is also considered as a conjunctival infection, which is caused by bacteria or viruses. Therefore, it's highly contagious. So pink eye is highly contagious, and conjunctivitis is not highly contagious. As I mentioned before, because the nasal cavity mucosa is continuous with the mucosa of the lacrimal duct system, so a cold or nasal inflammation often causes lacrimal mucosa to swell, and swelling constricts the ducts and prevent tears from draining, which causes the watery eye when you get nasal mucosa inflammation. Based on the movements, considering the clinical, as one of the clinical scenarios would be the diplopia, we call it as double vision, which occurs when movements of the external muscles of the two eyes are not perfectly coordinated. So the person cannot properly focus images of the same area of the visual field, and so see two images instead of one, and this could be result from paralysis, extrinsic muscle weakness, or certain neurological disorders. And also you might have heard the word strabismus or cross eye. This is a congenital weakness of external eye muscles. Eye rotates medially or laterally, and that would alternate focusing on objects or only controllable eye is used. And then what will happen is the brain begins to disregard inputs from the deviant eye, which can become functionally blind if not treated earlier. So that's why if you detect strabismus in early childhood, you would need to correct it with maybe exercises or with spectacles, so on. So the structure of the eyeball is that eyeball contains three layers: fibrous layer, vascular layer, and the inner layer. And the internal cavity of the eyeball is filled with a fluid called humus. And based on where this humor is, you would define them either vitreous humor or the aqueous humor. And the lens separates the internal cavity into anterior and the posterior segments. So this is the three layers you would see, as well as you would see the anterior chamber, the posterior chamber, the lens, the aqueous humor, the vitreous humor, so on. So you need to know the structures of the eye in a sagittal section. So let's go over several structures of the eyeball. Let's talk about the fibrous layer first. It's the outermost layer, which is dense as well as composed of avascular connective tissue, which means like there's no blood supply, but it's been supplied by the nutrients, and the oxygen is through diffusion, so on. The two regions of the fibrous layer are the sclera and the cornea. The sclera is the opaque posterior region which protects and shapes the eyeball. It anchors extrinsic eye muscles. Posteriorly, it continues with the optic nerve, and it also continues with the dura mater of the brain. The cornea is the transparent anterior 1/6 of the fibrous layer that you would see. It forms the clear window which lets the light enter and blends light as it enters the eye. The epithelium covers both surfaces, and the outer surface protects from abrasion. The inner layer composed of corneal endothelium, which contains sodium pumps and which helps to maintain the clarity of the cornea. And also, numerous pain receptors contribute to the blinking and tearing reflexes of the eye. The vascular layer is the second layer. It's the middle layer, which is pigmented layer of the eye and also called as uvea. There are three regions in the vascular layer: choroid, ciliary body, and the iris. The choroid region is the posterior portion of the uvea, supplies blood to all layers of the eyeball, and brown pigment of the choroid absorbs light to prevent scattering of the light, which would cause visual confusion. And the ciliary body is the located anteriorly. It's the choroid becomes ciliary body anteriorly, and it's a thickened ring of tissue surrounding the lens, consists of smooth muscle bundles, which we call as ciliary muscles, and it controls the shape of the lens. And the capillaries of the ciliary processes secretes a fluid for anterior segment of the eyeball. And there's a word called ciliary zonule, or the suspensory ligament, which extends from the ciliary processes to the lens, and it holds the lens in position. The iris is the colored part of the eye which lies between the cornea and the lens, and it continues with the ciliary body. So on the iris, you encounter the pupil. It's a central opening. It's not a structure, it's actually an opening which regulates the amount of the light entering the eyes. So during the close vision and bright light, this causes the sphincter pupillae, which is the circular muscles, to contract and pupils to constrict by this parasympathetic control. With related to the distant vision and the dim light, it causes the pupil to be dilate, which involve the radial muscles, and it's under the sympathetic control. So changes in the emotional state, pupils dilate, and when subject matter is appealing, or it requires problems solving skills. So here you would see the sphincter pupillae muscles, which contracts the pupil. So the pupil constricts then, and then the size of the pupil decrease. And here you would see the two muscles types, the sphincter pupillae and the dilator pupillae. So in here you would see the dilator pupillae, which is controlled by the sympathetic nerve control, and it will dilates the pupil, which increases the size of the pupil, and you would see it's comparatively big. Then the inner layer of the eyeball. So the inner layer, we call it as the retina. It originates as an outpocketing of the brain. It contains millions of photoreceptors and transduce light energy. It contains neurons, glial cells, and there are two delicate layered, it's a two-layered delicate membrane. The outer layer is the pigmented layer, the inner layer is the neural layer. So here you would see the inner layer, the neural layer of the retina, and the pigmented layer of the retina as the outer layer. The pigmented layer is single thick cell lining next to the choroid, and it extends anteriorly, also covering the ciliary body and the iris. And the functions would be it absorbs light and prevents scattering. It has a phagocytosis activity, as well as it can store vitamin A. The neural layer, it's transparent layer which runs anteriorly to margin of the ciliary body, as well as it's composed of three main types of neuron photoreceptors: bipolar cells and the ganglion cells. And when the signal spreads from photoreceptors to the bipolar cells to the ganglion cells axons exit eye as the optic nerve. And in the neural layer, you would find the optic disc, where the site where the optic nerve leaves the eye. At the site you lack photoreceptors, so we refer to as the blind spot. And the retina, it has 250 million photoreceptors that are one of the two types. Either it would be rods or cones. So rods, they are rods photoreceptors. It acts on dim light, involved with peripheral vision, and more numerous and more sensitive to light than the cone. So no color vision or sharp images with rod, and the rods are greatest at the periphery in number. The cones, they have the vision receptors for bright light. They have high resolution and involved with color vision. In the macular lutea area at the posterior pole lateral to blind spot contains mostly cones. And in the fovea centralaris is the tiny pit in the center of the macular lutea, which contains all cones, so is region with best visual acuity. And when the eye movement allows us to focus in on objects so that the fovea can pick it up, the image properly. So here it will show us the rods in blue and the cones in yellowish color of the neural layer of the retina. And with related to the blood supply, there are two sources of blood supply to the retina: the choroid supplied outer third, and the central artery and the vein of the retina supply the inner 2/3 of the eye. Clinical importance, you might have heard the word retinal detachment, where the pigmented and neural layers separate, they're detached, with allowing jelly-like vitreous humor to seep between them, and it could lead to permanent blindness and usually happen when retina is torn during traumatic blow to the head, accidents, somebody hitting the head, and sudden stopping of head during movements, jumping, and so on. And symptoms described as the victims as curtain being drawn across the eye and soot-like spots on light flashes, and reattachment of retina with laser surgery is the current treatment option for that. Let's look at the other structures of the eye. Let's look at the two chambers, the internal chambers and the fluids of it. So the lens and the ciliary zonula separates eye into two segments, the posterior segment and the anterior segment. The posterior segment contains vitreous humor, a fluid-filled cavity which transmits light, supports posterior surface of the lens, and it also contributes to the intraocular pressure. The vitreous humor forms in the embryo and lasts whole lifetime of an individual. The anterior segment, iris divides the anterior segment into two chambers: the anterior chamber between the cornea and the iris, and the posterior chamber between the iris and the lens. So entire segment contains, the anterior contains aqueous humor, which is a plasma-like fluid continuously formed by capillaries of the ciliary process. And it supplies the nutrients and oxygens mainly to the lens and cornea, but also to the retina, and do a function of removing of waste. And this figure you would see the aqueous humor forms by the filtration and the capillaries, the process of circulation of the aqueous humor, and you would see the steps involved with. Some of the clinical importance of this anterior chamber and the fluid. You might have a common known word, glaucoma, which is a condition where the drainage of the aqueous humor is blocked, causing the fluid to be back up and increase the pressure within the eye. And the pressure may increase to dangerous levels and compress the retina and the optic nerve, which leads to blindness. And the patients presents with some few early signs, but late signs include seeing halos around lights and blurred vision. And you need to detect it as soon as or early as possible. And the detection involved intraocular pressure checking and determined directing puff of air at the cornea and measuring amount of the corneal deformation. And the test should be done yearly after age of 40 because there's more tendency to develop glaucoma after the age of 40. And the treatments would be eye drops, which increase the rate of aqueous humor drainage or decreases production, or laser therapy by surgery. The lens is another important structure of the eye, which is biconvex, transparent, flexible, and avascular. And changes to the shape happening, and that will lead to several conditions. So, but the lens can change its shape to precise focus light on the retina. And the lens can be divided into two regions: the lens epithelium, which is anterior region of the cuboidal cells that differentiate into lens and fiber cells, and the lens fibers, which forms the bulk of the lens and filled with transparent protein called crystalline. And lens fibers are continually added, so lens becomes more dense, convex, and less elastic as we get old. So clinically, we call clouding of lens, which is a consequence of aging or diabetes or heavy smoking, frequent exposures to intense sunlight, and it could be sometimes congenital. And also clouding of lens ultimately leads to cataract, and vitamin C, excess amount of taking vitamin C could increase cataract formation too. So the treatment would be replacing of the lens with surgeries with an artificial lenses. So after the first presentation of the eye, let's go over the part B, and let's look at some of the light and its features and optics with related to the eye. So I respond only to the visible light, and in your PDF, which I have uploaded in the D2L, you would see more information of the visible light, the separate wavelengths which you need to refer to. So with related to the light and the visible ability, we can have several conditions as well as some physics of it. So refraction of the lens is a phenomenon that you would see, where the refraction means the bending of light rays. It's due to the change in the speed of the light when it passes from one transparent medium to another, and path of the light is at an oblique angle, as you would see in the picture shown it in here. So lenses of the eye can also refract light because they are curved on both sides. So convex means the thicker in the center than at edges, and concave, the lenses are concave and they're thicker at the edges than in the center. So here in the convex lenses, it bends the light passing through and the rays converge at a focal point. So here, this is a convex lens, and the rays would converge into focal points. For instance, this ray and this ray, like that. So image which is formed at the focal point is upside down and reversed from left to right. That's another important factor. So if you see here, if you make an arrow over here, then the arrow pointing should be in this way. And you would see that in here, the image inverted upside down and reversing. So upside down, the purple is now up here, as well as reversing seen at the side. You would see this orange color. So focusing light on the retina, pathways of light entering the eye are the cornea, aqueous humor, lens, vitreous humor, entire neural layer of the retina, and finally to the photoreceptors. So during this pathway, light is refracted 3 times, that is at the entering cornea, entering the lens, and leaving the lens. So majority of the refractory power is in cornea. And lens is able to adjust its curvatures to allow for fine focusing, and it can focus for distant vision and for close vision as well. So that's a ability of lens. Let's look at the focusing for distant vision. So eyes can be best adapted for distant vision, and the far point of vision, the distance beyond which no change in lens shape is needed for focusing. For normal eye, which we call as emmetropic, is the 20 feet, and the cornea and the lens focus light precisely on retina at this distance. In this case, ciliary muscles are completely relaxed, and it causes a pull on ciliary zonula. As a result, lens are stretched flat. So, with related to the close vision, light from close objects, which is less than 6 meters, diverges as approaching eye. And it requires eye to make active adjustments using 3 simultaneous processes, which is the first one is the accommodation of the lenses. We change the lens shape to increase the refraction. So the near point of vision, closest point on which the eye can focus, and in presbyopia, the loss of accommodation over the age 50 happen with related to the accommodation of the lens. The second process would be the constriction of the pupil. So we call it as the accommodation pupillary reflex, which involves the constriction of the pupils to prevent most divergent light rays from entering the eye. And this is mediated by the parasympathetic nervous system. The third process is the convergence of the eyeballs, which is the medial rotation of the eyeball causes convergence of the eye towards the object being viewed. So this is controlled by the somatic motor neuron innervation on the medial rectus muscles. The clinical scenarios involved with refraction and focusing of the light is that there are several refraction related to eyeball shapes, like myopia, nearsightedness. The eyeball is too long in this individual, so focal point is in the front of the retina, and you have to use the concave lenses to correct it. Hyperopia, the farsightedness, the eyeball is too short, so focal point is behind the retina, and it's corrected with a convex lens. And this condition called astigmatism, unequal curvatures in different parts of the lens or the cornea, which is corrected with cylindrical ground lenses or laser procedures. So here you would see the normal eye, the amyotropic eye, the myopia, where the eyeball is too long, so the focal point is much more closer. Then, so we have to make it focusing into the retina. So you have to use the concave lenses to make it make the image lens onto the retina. This is the hypertrophic eye, which is hyperopic eye, which is the eyeball is too short, and the image is landing farther away from the eyeball, and you have to bring it back into, and you have to use the convex lenses. The next important topic would be the phototransduction, the functional anatomy of the photoreceptors. As we know now, we have known 2 types of photoreceptors, rods and cones. They are modified neurons which resemble upside down epithelial cells. The photoreceptors consist of this phototransduction consists of cell body, synaptic terminal, and 2 segments. That is the outer segment, the light receiving region, which contains the visual pigments that change shape as they absorb light, and the inner segment of each joint cell bodies, and it's connected via the cilium to outer segment and to the cell body via the outer fibers. The cell body is connected to the synaptic terminal via inner fibers, and then the plasma membrane of the outer segment folds back to form many discs. And the clinical scenario would be photoreceptors are very vulnerable to damage, and it degenerate if retina is detached or can be destroyed by the intense light as well. Rods are very sensitive to light, making them best suited for night vision and peripheral visions. Cones have low sensitivity, so require bright light for activation, and cones can react more quickly than rods and have one of three pigments which allow for different colored sites. So here you would see a table which shows the comparison of the rods and cones. I would like you to refer to this table and look at the similarities and the differences. The clinical scenario with related to the photoreceptor transduction and the color vision will be the color blindness. Lack of one or more cone pigments leads to color blindness. It could be an inherited X-linked condition, so more common in males. As many as 8 to 10% of males have some form of color blindness. The most common type of color blindness is the red-green, in which either red cones or green cones are absent, and you would see the color depending on which cones is absent. And after that, let's look at some visual pigments involved with the vision. So some of the visual pigments, the first one would be the retinal. It's a key light absorbing molecule which combines with one of four proteins called opsin to form visual pigments, and it is synthesized by vitamin A. There are four opsins, the rhodopsin found in rods only, and three found out of the four opsins, rhodopsin found in rods and three found in cones, which gives the green, blue, and red. And then the cone wavelengths do overlap, so same wavelengths may trigger more than one cone, enabling us to see variety of colors. The phototransduction process is by which pigment captures photon of the light energy, which is converted into graded receptor potential. So with related to the capturing light, the deep purple pigment of the rods is rhodopsin. They are arranged in rod's outer segment. 3 steps of rhodopsin formation and breakdown is happening, pigment synthesis happening, and then bleaching and pigment regeneration process. So similar process in cones happen, but different types of opsins and cones require more intense light. With related to the pigment synthesis, opsins and 11 cis-trans retinal combine to form rhodopsin in the dark. And during the pigment bleaching, when rhodopsin absorb light, the 11 cis isomer of the retinal change to all trans isomers, so retinal and opsin separates. So that is called the bleaching rhodopsin breakdown. The pigment regeneration, all trans retinal converted back into the 11 cis isomer, and then the rhodopsin is generated in the outer segment. So if you would notice, the 11 cis retinal is the one which you need to see, and therefore like breaking down into all trans, and then regeneration bring back the 11 cis isomer back. During the light transduction reactions, light-activated rhodopsin activate G protein transducing, and this transducing activates a kind of a second messenger involvement process. It's G protein coupled, as you would see. So the G protein coupled receptors would be activated by the rhodopsins, and then the transducin involved with activating of the PDE then breaks down cyclic GMP, the second messenger. In the dark, the cyclic GMP holds cation channels at the outer segment, which opens up the sodium and calcium ions, which leads to depolarization of the cell. And when the cyclic GMP breaks down, this channel closes and then cells leads to hyperpolarize. So the important fact, unlike the nerve signals, the hyperpolarization process is a signal for the vision. So that is very important. So with related to the information processing in the retina, the photoreceptors and the bipolar cells generated only graded potentials, not the action potentials. And when light hyperpolarizes, the photoreceptor cells, they stop releasing inhibitory neurotransmitter glutamate, and the bipolar cells, they no longer inhibited and depolarizes, releases neurotransmitter into the ganglion cells, and these ganglion cells then generate the action potential, which is transmitted into the optic nerve and to the brain. So that is important. So with related to the process called light and dark adaptation, it is very important because you would experience this, like sometimes when you are outside with bright light and suddenly go inside, you would see like much more darker. It takes some time or while to get adapted to the inside darkness. So let's look at this process. So rhodopsin is so sensitive that bleaching occurs even in starlight. So even for a very smaller kind of a light. So in bright light, bleaching occurs so fast that the rods are virtually non-functional. Then cones respond to bright light. So activation of rods and cones depends on the light adaptation as well as the dark adaptation. With related to the light adaptation, when moving from darkness into bright light, we see glare because both rods and cones are strongly simulated and large amounts of pigments are broken down instantly, producing a glare. So the pupil starts to constrict. And visual acuity improves over 5 to 10 minutes as rod system turns off. Then the retinal sensitivity decreases and the cones and the neurons would rapidly adapt. But related to the dark adaptation, when moving from bright light into darkness, we see blackness because the cones stop functioning in low intensity light. The bright light bleached rod pigments, so they're still turned off, but the pupils are dilated. The rhodopsin accumulates in the dark, so retinal sensitivity starts to increase, transducing returns to outer segment, and the sensitivity increases within 20 to 30 minutes, which take a little bit longer time than the light adaptation. Certain clinical aspects with related to the topics that we have discussed is nyctalopia, which is the night blindness, is a condition in which rod function is seriously hampered, and also due to the rod degeneration, it is commonly caused by prolonged vitamin A deficiency. So therefore, vitamin A supplements restore the function of the rods. And this night blindness also can also be caused by retinitis pigmentosa, which is the degenerative retinal disease, which destroys the rods. After discussing this, we need to know the next topic would be that we need to discuss about the processing and relaying of visual information. So in there, we have to look up some of the visual pathway to the brain. So axons of the retinal ganglion cells form the optic nerve. Medial fibers from each eye cross over at the optic chiasma and then continue on as the optic tract. Tract contains fibers from the lateral, temporal aspect of the eye on the same side and the medial aspect of the opposite eye. So each carries information from same half of the visual field. Most fibers of the optic tract continues onto lateral geniculate nuclei of the thalamus, and it from there thalamic neurons form optic radiation, which projects to the primary visual cortex in the occipital lobes. So the conscious perception of the visual image happens at the primary visual cortex in the occipital lobes. So other optic tract fibers, they send branches to the midbrain. That is, one set ends in the superior colliculi, which is an area which controlling the extrinsic eye muscles. A small subset of ganglia cells in the retina contains melanopsin, which projects to the pretectal nuclei and involved in the pupillary reflex. The suprachiasmatic nucleus of the hypothalamus is the timer for the daily biorhythms. So here you would see the visual pathways to the brain and the visual fields based on the inferior view. You would see the medial aspect of the eye crossed, and then the lateral aspect, they do not cross. So if you take the optic tract over here, that you would contain the lateral aspect of the right eye and the medial aspect of the left eye fibers, like that. And here is the anatomy. After traveling the nerve impulses, then the perception needs to happen. So both eyes will save image from slightly different angles, and the visual cortex fuses these slightly different images, resulting in a three-dimensional image, which leads to perception. Not a 2D process, is a 3D process. So the two images fuses and formed and identify it as 3D images at the visual cortex level. So for that, it requires input from both eyes. The clinical aspects of the topics is that loss of an eye or destruction of one optic nerve eliminates the true depth perception entirely. So the peripheral vision on the damaged side is also affected. And if neural destruction occurs beyond the optic chiasma, then part or all of the opposite half of the visual field is lost of that individual. For instance, like some patients undergo stroke, which can affect the left visual cortex, and it could lead to blindness in right half of the visual field of that individual. The next important topic would be the visual processing. That is where the retinal cells split into channels, which includes the information about the color and the brightness. And it also contains complex information such as the angle of an image, the direction, speed of movement, the edges, so on. And during the visual processing process, the ganglions pass information to the lateral geniculate nuclei of the thalamus to be processed for depth perception, and the primary visual cortex, which contains the topographical map of the retina. And on this, the neurons respond to dark and bright edges and to the object orientation, and provide form, color, motion inputs to visual association areas. And the information is also passed on to temporal, parietal, and frontal lobes as well. So this is the end of the presentation B. And for further information, you need to read your textbook as well.